Namaste. Welcome to this special session of She and Rights Live from Women Deliver Conference 2026, which is being held in Narrm, Melbourne, in Australia. The theme of this session is Centering Breast and Cervical Cancer Prevention and Care in Gender Justice, Rights and Evidence. As you all know, She and Rights live sessions at the Women Deliver Conference 2026 are being hosted at the D03 Exhibition Space in Melbourne Conference and Exhibition Centre. All sessions are hybrid, live streamed, and host online and on-site speakers and participants, including media. She and Rights is co-hosted by Global Center for Health Diplomacy and Inclusion, or SETI, as we call it, and CNS, with partners like Women Deliver Conference 2026, International Planned Parenthood Federation, IPPF, Asian Pacific Resource and Research Center for Women, ARROW, Asia Pacific Media Alliance for Health, Gender, and Development Justice, or APCAT Media, and Health TV Online Nepal. This session focuses on two most prevalent and deadliest cancers amongst women, breast cancer and cervical cancer. Breast cancer and HPV-related cancers occur in men and other genders too, but disease burden and deaths is disproportionately higher in women. As per science, what we comprehend, cervical cancer and other HPV-related cancers are the only vaccine-preventable cancers. Despite having highly sensitive and specific screening tools for HPV, like molecular tests, which are used for TB also, we are still using less sensitive screening tools like visual inspection by acetic acid, VIA, and pap smear. Likewise, for breast cancer, we have highly painful mammography despite the fact there are more sensitive and specific tools that do not violate the privacy of girls and women and men and other genders, as well as can also find presumptive breast cancer cases even in dense breast tissue, for example, in younger women. We can do so much better. No excuse for inaction. But all governments have agreed to end cervical cancer by the turn of the century. When we have vaccines against deadliest strains of HPV and highly sensitive screening and diagnostic tools to find HPV cancers in precancerous stages, even before the cancer is formed, then why cannot we do better? Why wait till the end of the century? But we must make cervical cancer history in our lifetimes. Australia is one nation that has led from the front with high vaccination rates and screening tools and linkage to care. It has already reached almost elimination levels of cervical cancers in certain populations or age groups. Without any further ado, let me invite Professor Dr. Amita Pandey, Department of Obstetrics and Gynaecology and Dean, Faculty of Nursing, King George's Medical University, KGMU. Over to you, Dr. Amita. No, you are muted. You are muted, please.
Thank you so much. Am I audible now?
Yes, very audible.
So a very good morning from India to all of you. And thank you so much for giving me this wonderful opportunity to interact with such a learned audience who is listening to me. I'm speaking from India, from a premier tertiary care research and teaching institute called King George's Medical University. And I'm a professor of obstetrics and gynecology, and I'm involved in day-to-day care of women with cervical cancers. And as we all know, and as has been already discussed, breast and cervical cancers remain the leading cause of cancer-related morbidity and mortality among women in India. And this reflects not only biomedical challenges, but also deep-rooted gender inequities like patriarchal norms, gender-based discrimination, unequal power dynamics. All these factors often delay health-seeking behavior and limit women's autonomy in decision-making, and they also restrict access to preventive services. So, we all do agree that centering gender justice requires acknowledging women's right to timely, respectful, affordable, and quality cancer prevention and care across the life course, which is the need of our in India. In a developing country like ours, due emphasis must be paid to prevention and early detection of breast and cervical cancer, because as Shobhaji rightly mentioned just now, both these cancers are extremely preventable, provided due preventive strategies are adopted and early screening methods are used for early detection and timely management of these cancers. Now, breast and cervical cancer screening should be viewed as a fundamental reproductive and health right of women. And women must be empowered with accurate information to take autonomous decisions regarding HPV vaccination, regarding the screening, and regarding the available treatment options. As I am a gynecologist, I would focus my deliberation to cervical cancer. And as far as cervical cancer is concerned, we all know that there is enough evidence which supports population level interventions such as HPV vaccination and cervical cancer screening, which could be in the form of HPV testing, or where it is not available or it is found to be a little expensive, then VIA and VILI could be used, and this would in turn help in decreasing the load of the disease. Now, when we talk of prevention and HPV vaccination, I would like to again emphasize that HPV vaccination supports girls' right to preventive health care, shifting the focus from late-stage treatment to early and evidence-based prevention. And this can be done by using school-based and community-based delivery models in order to promote gender equity. Moreover, till now, we had the expensive internationally manufactured HPV vaccines, which were pretty expensive as far as developing countries were concerned. But now we have the indigenous Cervavac also, which has now been developed in India. So I think universal vaccination is possible and feasible because it's a very cost-effective HPV vaccine manufactured indigenously in India against HPV 16 and 18, which are responsible for the majority of the cancer cases in India. And initial tests have revealed good immunogenicity of this vaccine. Because the cost of the vaccine is very low, it can enable potential inclusion in the universal immunization program that is run by the government of India. And this would allow making it a large-scale, publicly funded vaccination, which is feasible and sustainable. Now, when we talk of screening, we have to go in for population-based screening. So for that, let me inform the audience that India has proper national initiatives such as the NPCDCS, which is the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke in place. And this program provides a strong policy framework for population-based screening of breast and cervical cancers. Unfortunately, however, effective implementation requires ensuring equitable access for women from rural, socioeconomically disadvantaged, and marginalized communities. So, aligning these interventions perhaps with the primary healthcare platforms such as the PHCs or the health and wellness centers that have been developed by the government of India under the Ayushman Bharat program, which allows free treatment to all, we can definitely improve coverage in the coming years while addressing gender-related barriers to access. Apart from that, community engagement, women empowerment, women education, and continuous monitoring would also contribute significantly and go a long way to ensure that these national programs are in place and are equitable and effective. So I feel that HPV vaccination integrated with continued cervical cancer screening strategies. Even if it is being done by just VIA and VILI, which are low stakes screening strategies, it has the potential to substantially reduce cervical cancer incidence and mortality in a country like ours and significantly reduce long-term healthcare costs. Thank you very much for your patient hearing. If there are any questions, I would love to
Professor
address
Amita. Thank you, Dr. Pandey. And thanks for rooting for gender justice in your talk and also for focusing on prevention. You have really set the stage to take the session forward. I now invite Dr. Kuldeep Singh Sachdeva, former head, that is Deputy Director General of Indian Government's TB and HIV programs, Ministry of Health and Family Welfare, former Southeast Asia Director of the Union, and currently President and Chief Medical Officer of Molbio. Thanks, Dr. Sachdeva. Over to you, sir.
At the outset, thank the organizers for giving me this opportunity to speak at this important event. I also put on record my gratitude to Citizen News Service for again giving me this opportunity. The topic of the day today is that cervical cancer is vaccine preventable, and it has highly sensitive and specific screening tools to detect it early enough, but it still continues to be among the lead cancers in women and men. Let me start by saying that cervical cancer is a devastating and a preventable global inequity. Every year you see about 660,000 new cases of cervical cancer globally, including 350,000 deaths. It is the fourth most common cancer in the women. Also, point to notice that 94% of the global cervical cancer deaths occur in low and middle income countries. The incidence in women living with HIV is almost 6 times more likely than in the general population. A similar story is in a country where I belong, which is India. So you see about 123,000 new cases annually in India and about 77,000 deaths. We bear a disproportionate burden of cervical cancer, amounting to nearly a fourth, which is 25% of global cases. 95% of the cases are caused by persistent infection with high-risk human papillomavirus. The WHO has targets for elimination, which is prevent 90% through vaccination, screen at least 70%, and those screened treat the 90% who need treatment. India bears the second highest cervical cancer burden globally. This cancer is entirely preventable, and as already alluded, persistent infection with high-risk human papillomavirus is the primary cause, and that is where early and accurate detection becomes our most powerful intervention. A word about human papillomavirus. So it's a very diverse virus. You have almost 200 genotypes of human papillomavirus, but not all genotypes are high risk. You also have low risk human papillomavirus, which is HPV 6 and 11, and these types are most commonly associated with benign conditions such as genital warts and respiratory papillomatosis, and they rarely cause cancer. The high-risk types are the most common one are 14 and 17, which cause nearly all cervical cancers. 16 and 18 are responsible for about 70% of invasive cervical cancer, and other high-risk types are 31, 33, 35, 45, 52, 52, and they are responsible for additional 20% of the risk pool. So globally, while HPV 16 and 18 dominate the global discussion, the other high-risk types just mentioned are equally as important, especially in Asia and Africa. And the screening tools are now evolving to cover more and more high-risk types at least 8 high-risk types. Some countries detect around 13 to 14 high-risk types. This picture tells you the diversity in HPV infection amongst various continents. Globally, on an average, about HPV prevalence is about 10% in healthy women. It rises to about 13.8% in North America, 14.3% in South America. In Central America and Mexico, it is about 20.5%, and in Africa, it almost exceeds about 23%. Asia and Europe report a lower HPV prevalence among healthy women, lowest being in Europe, which is around 7%. And within, so as we see the diversity within continents, similarly in our country, which is India, you see diversity in various states and provinces. So not all states and provinces have an equal propensity to infection with the high-risk HPV types. And what is more important is not the infection with HPV, because most infections in early life clears within 1 to 2 years, which is 12 to 24 months, over 70% clear. So, but those infections which do not clear and then they are called as persistent infections, they cause about 35 to 40% of the high-risk HPV cases globally. Among various HPV types, type 52, 58, 35 show higher persistence in Asia and Africa. The persistence result in development of a precancerous lesion, and it's a very silent development. You don't actually feel the symptoms of it. That is where, if there is a persistence, we need to get worried and we need to sort of detect them as early as possible. These silent carriers are the ones who drive progression to high-grade lesion and cancer, and that is why now there is a decision and global acceptance that we must detect as many high-risk genotypes as feasible, and it is quite crucial. And now the narrative is that at least 8 genotypes, and in some countries about 13 to 14 high-risk genotypes must be detected. Now, the burden of human papillomavirus infection and the disease it causes in male and females. In females, we all know that it is the causative agent for cervical cancer. It can also cause vulvar and vaginal cancer, anal cancer.
We cannot hear you, sir. I think you have lost connection, Dr. Sachdeva.
Rising incidence of oropharyngeal cancer. It can also cause anal cancer, penile cancers, and genital wart. Even though it affects both sexes, causing a spectrum of cancers and conditions. And that underscores the importance of universal vaccination and screening in both sexes, even though the guidelines generally allude to vaccination and screening among girls and women, but it's an equally applicable to men as well. As I already alluded, the HPV infection mostly triggers, that is where you see that from a normal cervix, which gets HPV infection, then you see an arrow which shows a reversion again to normal cervix. So that is spontaneous clearing of HPV infection. But some HPV infection will persist, and that is when, if there is more persistence than a silent carrier, it grows to a high-grade carcinoma and finally a full-blown cancer. And below you see when do we actually can detect these early enough through pap smear and visual inspection through acetic acid is when the persistence is fairly advanced. Whereas molecular tests can detect HPV infection at a much earlier stage, even before they go into a persistence. So that is where the lies the importance of early screening and detection and sort of an action on those screening algorithms. But WHO stated the global strategic targets known as 90, 70, 90, which means 90% girls and I will say boys are fully vaccinated with HPV vaccine by 15 years of age. That's the first window of which is the prevention, which is the primary prevention with a vaccination. Later on, screen at least 70% of women with a high performance test, which is a molecular based test, by 35 years of age and again by 45 years of age. So you screen them every 5 to 10 years after a certain age of 30. Amongst those who are detected with the cervical precancer or an invasive cancer, 90% of them must receive treatment. So the basic point being stressed here is that don't just test to detect them early enough to offer us treatment at an early stage of cancer so that we don't reach an advanced stage of cancer and we are able to cure cancer at a very, very early stage. Coming to vaccination, so there are, again, WHO has issued guidelines for vaccination. For girls between 9 to 14 years, it's either 1 or 2 doses. Between 15 to 20 years, again, 1 or 2 doses. And beyond that, you invariably need 2 doses at 6 monthly intervals. And for immunocompromised HIV, you will need 2 to 3 doses for optimal effect. So that's the primary prevention with the vaccination, and it's almost universally. If you can target 70% of those who need such primary prevention, we will do a great justice to public health and the other parameters of development. Now, a word about high performance test to screen once we have crossed the age of primary prevention, and people are now into an age which is that by after an age of 25 or 30, then you need to screen that high performance test. One of the high performance tests is a molecular test for human papilloma virus, and one such test is where you collect a swab. It can also be it can either be a physician collected or a self collected swab. Extract the DNA through a rapid lysis, amplify the DNA through a PCR, and we get a result within next 1 hour. So this is one such test is called a TrueNAT test, which is capable of testing 8 genotypes of human papilloma virus currently, and in the process of adding another test which can detect 14 genotypes. This test known as TrueNAT HPV-HR plus is rapid, reliable. It's also point of care, ready to scale. You can do it in any geography. It's battery operated. So it's a real-time PCR that was highly sensitive molecular level detection of high-risk HPV DNA before clinical disease development. Targets the high-risk groups which are already alluded to. It's battery operated, low temperature stable, and reagents are designed for rural and low resource settings. There's another method of primary screening which is taking a pap smear, but pap smear suffers from some bottlenecks that it does not detect all cases of it's dependent upon the operator who is taking the smear and who is examining the smear. So its sensitivity and specificity is very low compared to DNA test, which is a HPV-HR PCR test. However, in low resource settings, it is also recommended that you can screen through a pap smear. So the recommendation is that for a highly sensitive and specific test, you should go for an HPV DNA to a PCR test. There's also a talk of screen and treat continuum within the WHO guidance, which says once you have detected, treat 90% of those who have been detected to be showing persistence. and have some lesion on their cervix. So basic detection without intervention is a failure of care. Point of care PCR enables providers to find precancerous lesions and treat them in the same visit. So immediate intervention, which can be a thermal ablation, where a heated probe rapidly destroys abnormal cells, or a cryotherapy, which is a cold probe application to freeze and destroy lesions, or electrically heated loop to surgically remove abnormal transformation zone tissue. So it's the same day treatment of precancer is highly effective, very low discomfort procedure that permanently stops progression to invasive cancer. And this is the last slide, which talks about a stacked defense. If you have to eliminate cervical cancer, you need more than 3 tiers or layers. Layer 1 is the vaccine, which is highly effective, but do not cover 100% of HPV strains. And older generations missed adolescent vaccinations. So there is a generation which have missed adolescent vaccination, so the only option for them is a screening test. Layer 2 is a PCR screening, which catches high-risk persistent infections that evaded or predated vaccinations. And layer 3 is a pre-cancer treatment, which is the final backstop, utilizes detected precancerous lesions before they turn deadly. So now we have single-dose vaccines, which are again a breakthrough, but the elimination is only mathematically possible through the seamless integration of broad vaccination, decentralized polymerase chain reaction testing, and same-day treatment. And modeling has shown that you can avert 74 million number of new cervical cancer cases by 2120 if we follow the 90-70-90 paradigm and targets, and we are able to meet those targets. In the conclusion, I say that we now possess the tools, single-dose vaccine regimens, and miniaturized molecular diagnostics to make cervical cancer the first cancer ever eliminated by humanity. The strategy is clear and the mandate is seamless implementations. Thanks everybody for your attention. Now,
Thank you very much,
take any questions.
Thank you. Thank you, Dr. Sachdeva, for a very informative presentation. And let us hope HPV vaccination and also screening with WHO recommended science-based tools is rolled out equitably globally, especially for the underserved and with linkage to standard care. Moving forward, let us listen to Dr. Geeta Manjunath, founder and director, Niramai Health Analytics. Dr. Geeta and her team is taking point-of-care portable breast cancer screening closer to the communities. And Dr. Geeta, I would like to thank you at the outset for last year's screening free PLHIV women for breast cancer. And we have seen that your tool is working in remote areas of Meghalaya as well as in Punjab. Over to you, ma'am.
Sure, sir. Sure, ma'am. Thank you so much. Can you hear me okay?
Yes, we can hear you. Yes.
Yeah, so I'm not sure whether you can see me. Anyway, okay. Okay, so I'll just share my screen.
Yes.
So first of all, good morning, everyone. It's a real pleasure. Thank you so much, ma'am, for giving me an opportunity to speak here. So let me just share. So I'm going to sort of most part of the talk I'll focus on this new method of detecting breast cancer. But before that, let me give a quick view of the overall status of breast cancer in the world and in India a little bit more so, and what is being done today and how we can try to address coming together, right? All of us coming together. Thanks once again for the opportunity to share. we all know breast cancer is a major problem, but it turns out to be the leading cause of cancer deaths in fact, 159 countries in this world. Breast cancer is the top cancer of incidence. Remaining, it is the second, right? So it's really, really a major, major problem with over 684,000 women dying in 2020, and the latest number 2022 is also very similar. This means 2,000 lives go every day unnecessarily because nobody needs to die of breast cancer, but still we lose so many women to breast cancer. In fact, when you look at the breast cancer deaths around different continents, you actually sort of, if you count the pies, you will figure that 71% of these breast cancer deaths in the world are coming from low and middle income countries, clearly associated with affordability and accessibility. Many of these countries, LMIC developing countries, have mortality rates of greater than 50%. Every alternate lady detected with breast cancer is dying, when it's really possible to have 85 to 90% survival beyond 5 years, we are having 50%, which means definitely we need to do something. We are losing 2,000 lives unnecessarily, right? So the question next is why? Okay, some more. India, this is even more a problem. About 2 lakh women got detected with breast cancer 2 years ago in 2024, numbers known, whereas 1 lakh women died. That means every 6 minutes, we are losing one person in India to breast cancer. It is a really, really issue. How can we reduce this? So there are several techniques that are available today, and mostly for low resource settings, WHO has suggested clinical breast examination, hand-based examination, typically by a experienced health worker or, of course, a doctor preferably, right? But there's so much variability in the way you train an ASHA worker going in a village and so on. And so she may not know exactly how to do this clinical examination. Secondly, what happens in clinical breast examinations, you're looking for lumps and certain discharge and certain symptoms like skin changes, etc. And just because there is a symptom, it doesn't mean it's cancer. There could be benign lesions, benign lumps, etc. So unnecessarily, again, you're creating, mental disturbance in women. Just, oh, lump hai, to you have to sort of rush. So there are a lot of false positives. And also, you only can palpate a lump when it is lesion is 2 centimeters big, which is already stage 2 or more. So yeah, it is better to detect clinically first rather than accidentally after 5 centimeters of lesion, but it is not sufficient. We need to be able to detect much earlier, because earlier we detect, better is the treatment efficacy, that is ability to live longer, and also reduced treatment costs. If a stage 1 detection is looked at and then treatment cost is measured versus stage 4, it's almost, multiple times more, 10 times more cost, if a person is detected late. Then there is a de facto standard in the world called mammography, which most of us will know, which is an X-ray based test where breast is placed between the 2 plates here, and it's kind of compressed and X-rays are passed from top to bottom. And here what happens, looking at the density differences, because even microcalcifications, small lesions also will come out as white in an X-ray, which is typically black. Of course, experienced radiologists are able to detect these things. And this is pretty much the only test which has shown that it can reduce the cancer deaths by 13.8%, which is good. And that's why it's a standard. However, there are limitations, and I'll come to that quickly. Breast ultrasound is another method, which is also great, but you need a nice, senior, experienced sonographer or a radiologist to actually do this. It's like the ultrasound of the breast, similar to like you do ultrasound on the abdomen when a person is pregnant or having some issues with the abdomen, right? So you kind of put a gel and move on the breast to figure out if there is what we call as textural variations, echo. Hypoechoic mass, we say, so that we figure out if there is an abnormality or not. And then immediately, if there is something really suspicious, you can do a biopsy, which is ultrasound guided biopsy, and that would become a very kind of a confirmatory diagnosis before treatment. Now, the question is 2 things. How often can we get such nicely experienced radiologists everywhere, particularly when we talk about underserved areas and rural areas? Second, There have been misuses of an ultrasound outside the hospital setting for fetal sex determination, and that has resulted in some legal framework which does not allow us to take ultrasound outside a hospital without certain conditions and permissions. So it rules out outreach and it rules out rural kind of detection in the primary care itself. So that is where our test comes in, which is Narrm thermalytics, which I'll share more. In the interest of time, I'll skip this. So because of some of the limitations, okay, maybe I will share. So as I mentioned, clinical examination detects palpable lump only, which is about 2.5 centimeters. Mammography actually has some limitations in younger women. It's only recommended above 45 years of age, whereas in India and many countries in Asia, we see so many younger women detected, affected by breast cancer. In fact, this number is going so high that the mean age for breast cancer is becoming around 52, which means almost 50% of women are under 50. It's like really bad. And because of the experience of doing a mammogram, many people run away. And I already told about mammogram. So how can we address all this? And what is the result of these sort of, limitations? The result clearly is that the number of women who are taking the standard mammogram, which is really the global standard, is really becoming very low. In low and middle countries, primarily for affordability and accessibility reasons, you'll see India has a screening rate of 1.3%. That means if you ask any lady between 40 and 69, have you ever had a breast cancer screening with mammogram? The answer is 1.3. Not have you had in the last 2 years, ever had, which is really pathetic. Whereas the same number is 76% in US. So we need definitely an affordable, accessible method to do. And also address the user experience and address the issue of dense breasts. What is this issue of dense breast? If a person has dense breast, the whole breast appears white because an X-ray of the breast is usually X-ray shows, high. I mean, it is the nature that X-ray shows high density as white color. So if the whole breast is white, how do we find a white spot on a white breast? So now many regulations, including Australian regulations, of course, US FDA has already changed to say that there is a density reporting guideline. That is, any person who's having a mammography report should and is entitled to know her density of the breast. And if it is high density, she needs an MRI or another supplemental test. So this has become a global problem. And in many countries, it is under review. But mostly they send, like, even if you do a mammogram, you need to do an MRI as well, which is much more expensive and also less comfortable. So that is where we've invented this new method called thermalytics, where we measure the temperature variations on the chest using a thermal sensor and convert the temperature map to a cancer health report. Thermal analytics, so which is primarily AI driven. So the infrared imaging device measures 400,000, that is 4 lakh temperature points, and the AI comes in and converts that into a cancer health report. I'll tell more about it. With this, we are able to detect 4 millimeter cancer, which definitely can be considered as stage 0. It works for women of all ages, and it can work on men. It can work on neutral gender, who also sort of, left out on the general screening category. There's no radiation. We are just emanating infrared rays to the environment, and this is a passive device which captures that. Much more affordable, extremely portable, like a DSLR camera, as you rightly mentioned, Dr. Shobha ma'am. We've taken this out to Meghalaya, Uttarakhand, really the hilly regions, unreachable regions, and then say put it in the backpack and take it out into the screening. And last but the best is the experience of doing the test. It is a no-see, no-touch experience. They put a 4-wall kind of a curtain. The lady is inside. The technician also is outside. It's like a changing room. Close all doors and curtains and remove clothes. No one sees or touches the person. So there's a quick video where this is in a hospital setting. The curtains are closed. The technician is one side and the lady who's getting screened is just rotating on a stool to take the left and the right views. Before taking the image, of course, we blow cool air for about 5 minutes so that there is good contrast and better results that come out. That's about it. Very simple test. And the AI is the one which does the magic. It converts the Use of thermal sensing for breast screening was known, but it was not, and it is not so much adopted. And also it is a lot of errors because it's very hard to interpret this image with the bare eyes. Because if you see here, 35 degrees and 34 degrees, both can look red. And how can our poor naked eye differentiate? It is not possible. There are 4 lakh temperature points, 2000 shades, etc. So when we bring in the computer-aided analysis, we do not look at the image. We look at the temperature values directly, analyze it, and then generate an image saying, is there an abnormality or not? What is the probability that it is actually cancer? And also, where is it, so that we can mark the area of likely malignancy and send her for an ultrasound-guided biopsy. So this is a screening or an early detection tool where every person, whether symptom or no symptom, can actually do this test to at least rule out if there is an abnormality or not. Anything that is high risk or found to be positive here need not be always cancer. There could be what we call as false positives, but there will be some abnormality which will require attention. This software itself is very unique, made in India, in fact, invented in India, and has resulted in 40 granted patents. There's a lot of AI-based analysis. In the interest of time, I may not go into all of it, but AI uses for quality checks to make sure that this can be given to real health workers, staff nurses, CHCs, so that, we can really, make it more scalable, reduce the skill set and make it more scalable, usable, reduce the cost as well. And then a lot of AI to extract the right kind of minute thermal patterns, minute vascular patterns, which are indicative of early breast cancer. And then explainable responsible AI output, which generates red, yellow, green. That is easy for the health worker to understand. And then a detailed report for the radiologist to review only for positive patients, because then it works on the really, really affordable angle. A lot of clinical validation has been done in India, Europe, Africa, US, and many, many top publications. 56 publications are listed on our publications list. Everyone is welcome to go through it, and then happy to answer any questions. Just to share one of our first peer-reviewed publications published in 2020 in ASCO JCO. Here you see the overall sensitivity and specificity was about 90% and 82%. When we considered even screening sensitivity, that is no symptoms, we detected all cancers as well, right? So it really has very high levels of accuracy overall, and it is having very high negative predictive value. That means when we say no, it's a no. When we say yes, she requires a few more tests, but that too false positive rate is not so high. We've also done several rural screenings, going into the villages in different states, etc., and making the ASHA workers, taking the help of ASHA workers to create the awareness, taking the help of existing staff to conduct the screening, and also adding more staff if needed. One of the publications I want to share here is from WHO, Dr. Karthik Gadappa sir, in Punjab, where we did a study of 15,000 women, and 3% of them were found to be requiring a follow-up diagnostic workup. So instead of getting 15,000 women from different 189 locations where we did the screening and taking a mammogram there and doing for some of them, and some of them bringing them to a hospital to do MRI, ultrasound, if dense breast, etc., you have to bring in 460 people, only 3%. 97% of people have said, you're good, go back and come back every year. So it just makes breast screening possible at the edge, we say, right? Near where it's actually needed. And it definitely works. We have already seen the high sensitivity specificity. But what's also interesting is that if you had actually used clinical breast examination instead of this, then we would have missed 2/3 of the cancers. Why? Because there was another study by Japago and others, it was published in Cancer, which said 52,000 women screened around the same area, 24 final cancers detected. In our case, 15,000 women, 27 cancer detected. That means 3 times more cancers were detected in ours. Of course, still 32% follow-up only. That is, 2/3 of them did not share their follow-up reports. So it could be even 3 times this, unfortunately. So India is becoming unfortunate, area, region in the world where many, many women are dying of breast cancer. We definitely need some big action to take care of it and detect all cancers. Right now, of course, We do have regulatory clearance. We are one of the only startup which has an AI software to detect any female abnormality. And we have both US and Europe approval and several other countries. So far, more than 5 lakh women have benefited from this test because we were focusing more on the clinical efficacy and all in it. Locations in India are offering this solution. Thousands of camps have been done, and it's now available in 22 countries, including, some of the top hospitals. I don't know whether you can hear, maybe instead, like, Narrm Health, Apollo Clinic, Kaveri, HCG, Sakra, Kokilabed, all of them are using it. And most importantly, it's not just inside a hospital. We can take it out and do the screening in rural areas, as I mentioned, in urban areas or even garment factories. We can take it out and do the place wherever there is a group of people, we can do this test. And, it doesn't require any infrastructure requirements. So I'm happy to share this Make in India product going global. And shortly, we will probably come to Australia as well. And I think there are some Australian audiences. We already have a couple of doctors using it and really becoming strong. So overall, I think breast cancer is a top cancer. All of us have to fight. There are several tests already available. Please make use of them. And if it is not affordable, accessible, or you feel you need another test, we do have thermolytics, which can screen any lady about 25. In fact, we have found a 17-year-old with breast cancer with this. It does not have the age limitation because it is not based on density. Doesn't matter whether pregnant, lactating, symptomatic, asymptomatic, with surgery, without surgery, it actually does pretty well. And most importantly, population level screening. If the horse is not coming to the water, take the water to the horse. Please get everyone screened at least once. This has become my life motion, literally mission, I would say, because we need to stop breast cancer, and it is definitely possible because we have all the treatment facilities. As long as women are coming to get to these treatment facilities on time, then we can really stop deaths due to breast cancer. Thank you so much, and happy to answer any questions.
Thank you, Geeta ji, and all power to you for having this literally point of care testing, which is so very important, and also keeping the person's comfort in mind. Mammography is not an easy test to be taken by anyone, and again available in tertiary care hospitals. So all force to you, and we hope that more and more people are able to use this technology. With that, we conclude today's session, and we will see you in our next She and Rights live session from Women Deliver Conference 2020.